Hi, everybody. I am Lizzie Faust. I am co-owner of the Frank and Lizzie Show, and we're here to talk to you today about the basics of ostomy care. So, in the next 30 minutes, we're going to cover what an ostomy is, the different types of ostomies, why you might have one, different terms that you should be familiar with, whether you are an ostomate or take care of ostomates, how to empty a pouch, how to change a pouch, how to stoma site somebody, or if you are getting an ostomy or a stoma, what you should be aware of in terms of when they are marking the spot, accessory products, and skincare. And also be sure to stay tuned at the very end for a free resource as well. Okay, so what is an ostomy? Well, an ostomy is just a surgically created opening on the abdomen for elimination of urine or stool, and it creates a new way for waste to leave your body. This leaves people with often a better quality of life, or it could be a life-saving surgery to remove either their bladder or a portion of their bowel due to either a disease process or even to trauma. So the three main types of ostomies are you have a colostomy, which is a surgical opening made from the large intestines to the abdomen. You have an ileostomy, which is the stomas made from the small intestines, or a urostomy, which is also known as an ileal conduit. And this often occurs when the bladder is surgically removed or bypassed, and a conduit, or a passage essentially, is made from a short segment of the small intestines, and then the ureters drain directly into that small conduit. So ileal is that it's part of the ileum, and conduit is that it's a passage for the urine to exit through there. So, why would you have ostomy surgery? So, I'm just going through some of the common ones. Listen, if your specific disease state isn't on here, this is not all inclusive. So, often for colostomy, things like diverticulitis, if it's really inflamed or if it ruptures, inflammatory bowel disease, birth defects, cancers, bowel obstructions, injury, neurogenic disease as well. For ileostomies, you'll often see in inflammatory bowel disease, familial adenomatous polyposis, and birth defects and cancers. And then you have cancer, particularly of the bladder, birth defects, bladder diseases, or injuries as well. So what is a stoma? So the stoma is exactly what you see in that picture there. So it's that pretty little budded thing. That's how we like them to look. They should be red, moist, and stick out slightly from the skin around them. This stoma is just the opening, so it's actually made of a piece of your bowel. And so they can vary in sizes depending on what piece of bowel they take, what the status of your bowel is, and your body habitus has a lot to do with what it will look like as well. So for most ostomies, we have a pouching system as well, which is considered a prosthetic system because it's something that's being applied that is not part of you naturally. And that's continuously worn over the stoma to control the stool or urine. Now, there are some forms of continent diversions. Those are not going to be covered in this particular presentation, but we will talk about them on the Frank and Lizzie show in some of our episodes in the near future. So just in terms of different types of stomas, I like to bring up. So brooking is the process of basically where you bring up that loop of bowel and then you flip it onto itself. So that's called brooking. And it's essentially when you take the intestines, you bring it out, you flip it back onto itself, and then you sew it. And so you have that little bud sticking out. Then you have an end ileostomy where they just kind of bring up one section of that bowel and it's just a single tube. Or you have a loop ostomy, which is pretty common, particularly for temporary ostomies. The loop is when you actually bring up a whole loop of your bowel and then you would create an opening in that. Oftentimes you might see something like a rod in there as well. So again, this is just some images to show you. So they would open up the efferent edge and the afferent side. And then they create this stoma outside of it. And you can see there's this little tube that is in the middle there. And that is help holding up that loop of bowel while the sutures are healing just to help decrease some of the tension. Not every loop ostomy gets that, but you might see it if it's a brand new one. We typically remove that rod or that bridge around 7 days after the original surgery. And these are what different stomas can look like, and they're all perfectly normal. So an end stoma is typically a singular stoma that is by itself. It's typically circular. A loop stoma is two portions of the bowel directly next to each other. And so you'll almost see like two heads to it. So this will often be either wider than it is tall or taller than it is wide, depending on how they place them. And then it's also possible to have two stomas. So one could be the distal bowel and one could be the proximal bowel. So one would be active and the other would not be. And they're typically very close to each other, but they can be separate from each other as well. Sometimes we put them both in the same appliance, or sometimes they get two separate pouches for them. Okay, so this is just some basic anatomy. Often we'll see for diverticulitis, we'll often see a left colostomy because we're just trying to bypass as much of the bowel or as little of the bowel as possible. Same for spinal cord injury patients who are undergoing a colostomy surgery in order to help with their bowel training programs. If you have a transverse colostomy, it's going to be on the upper portion of your bowel there. Your transverse colon runs essentially from your right side underneath your rib cage over to your left side underneath your rib cage. So it could be anywhere across that upper portion, but it's typically right below your rib cage and right below your diaphragm. Or you could have a right-sided colostomy. So your right side of your colon runs down, obviously, the right side of your body, and then it directly meets up to your ileum, right where your appendix is. So your right lower quadrant of your abdomen. Now, your small intestines has a lot of bowels within it, and they're kind of all throughout. So it's not that kind of sharper distinction. But you could have an ileostomy that's typically found in the right lower quadrant of the abdomen, or a jejunostomy, which is going to be found in the left upper quadrant. Now, this is typicals. Everybody might have a different location based upon their anatomy. And then again, this is just how it's created. So just so you're aware, I like the image on the right. So that stoma is typically placed in the center of the rectus muscle belly. So one of the things as an ostomy nurse, when we're evaluating a patient and we're looking to mark a spot, or what we call stoma site a patient, we have to identify where their rectus muscle is. So we'll often ask them to either sit up from a laying to sitting position. We'll ask them to cough, just so we can palpate where their rectus muscle is. And we really want to make sure it's kind of dead in the middle of that muscle, because then that can help prevent the stoma from sticking out too far, which we might call a hernia, or making that muscle much weaker, which could also result in a hernia. And this technique has been around, I mean, for a very long time. I can remember Dr. or Professor Brian Brook first described this technique of brooking a stoma in order to minimize skin excoriation in 1947. And so this has been around for quite some time, and we've really come a long way, actually more so with the supplies as well. So just as I mentioned, this is the small intestines, and there is a lot of it. I once heard that you can take your intestines, which includes your large and your small intestines, and if you stretch it out, it would actually be the size of a tennis court. So that's kind of cool. One of the things that affects how well a stoma does is how well it's vascularized. So you have to the left, you have the distribution of the superior mesenteric artery, which is showing you the blood supply coming off of the aorta that's going to affect your transverse colon, your right side of your colon, and a portion of your jejunum and your ileum. Then on the right side, you have the distribution of the inferior mesenteric artery, which is going to be innervating and vascularizing the transverse colon on the right side, as well as the descending colon, the sigmoid colon, and the rectum. So surgeons need to be wary of this when we're looking at our vascular supply to make sure that when we are creating the stoma, that we're able to keep the blood flow to it so that that tissue does not slough off and die. So as I mentioned with stoma marking, there's a lot of key points to talk about. And the next 3 slides, we're going to talk about stoma siting a little bit more in depth. So stoma siting should be located in that rectus abdominis muscle that we discussed. We want to make sure we are positioning the stoma away from contractures. We want to make sure we look at your posture and your mobility. For example, if you're marking a patient that's always sitting in a wheelchair, make sure to evaluate them in a wheelchair and not laying flat on a bed. You want to consider physical issues, such as if they have a large protruding or pendulous abdomen, they have pendulous breasts, they have abdominal folds, wrinkles, scars, other stomas potentially. If they're where the rectus muscle is, where their waistline is, where they wear their pants, where what they do for work, things like that. You might want to worry about what their vision is, if they have good dexterity in their hands, if they already have a hernia present. And then things like what their diagnosis is, what their age is, what their occupation is, what their quality of life is, if they have any preferences. Surgical considerations could be like the type of surgery planned. Obviously, we wouldn't want to mark a stoma for a colostomy if they're getting an ileostomy. If it's a urinary stoma, you want to mark the fecal and urinary stoma sites on maybe different horizontal planes if they have both. So you just have to worry about kind of all of those, which is why it's best that if you are undergoing an ostomy surgery, that you ask to have a certified ostomy nurse meet with you ahead of time to both review your anatomy, pick a stoma site that would be of your best interest. Also, I like to draw all over and tell the surgeon where he or she should not go in order to help create the best location for the patient. And what I do during the stoma site marking procedure is I just gather up my items, which is like a marking pen or a surgical marker, transparent film dressing, and we explain the stoma siting procedure to the patient. We encourage their participation and feedback. I also typically bring a pouch with me so that they can kind of see where it would be, just to make sure they don't think they can see it and then maybe they can't. We take a look at the waistband, the elasticity. We look at them in varying positions, so sitting, standing, lying, bending forward. We look at hair distribution, all kinds of stuff. We'll ask them to cough and make sure that we can identify that rectus muscle. Whenever we do mark, then we identify whether or not it is within their field as well. And in the next slide, I'm going to discuss some of the challenges that we can face. So let's say we're marking a stoma on a patient that has a larger abdomen or maybe a more rounded abdomen. So you can see kind of that line of sight. So we would want to mark above that site in order for the patient to have the best options in terms of taking care of it. So looking at the side profile of your patient can be really helpful when you're doing this. And one of the challenges is that often surgeons are seeing the patient's full anatomy only when they're lying on the OR table, and they may not see all the things such as these folds that you can see here. So really ensuring that you know the anatomy of your patient, but there can be signs. So if you see creases or lines from like waistbands and things like that, you can see. So almost where those creases are, I would write X's on the patient's skin to tell the surgeon, avoid that. Or I would write them a message, the patient has a very rounded abdomen. Ideally, we can keep the stoma up higher so that they can make sure that they can see the stoma well in order to properly treat the stoma or take care of the stoma. Measuring guides. So these can be helpful, particularly for new ostomates or nurses who don't have a whole lot of experience with stomas. So these are really helpful when you're trying to figure out what pouch you need to get. So we can measure the stoma in order to find the most appropriate size pouch for him. And all of these can be normal size stomas. So I never like to to make anybody think that their stoma is not normal. But one thing you'll notice is that all of these are circular. And as I described before, um, there are stomas that may be wider than they are tall, or they're a little oblong. So for this purpose, you can use multiple circles to maybe get the width versus the height and something like that. But often if you have like an end ostomy, they're going to be circular versus a loop that's going to be a little bit more oblong. And sometimes, due to scarring or strictures, they take on an oblong shape even if they are an end ostomy. So this is a nice thing that you can do. And often I encourage my patients to measure at every pouch change for the first 6 to 8 weeks, because you're going to notice that it changes over time. You're often going to see a lot of swelling in both your abdomen and the stoma in the first 6 to 8 weeks. And then usually it settles down. But anytime you can experience a change, and these little guides are great so that you know that you're in the best appliance or pouching system that you can be. So let's just talk about some of the lingo that is important. So wafer, and we'll go through all of this. So wafer, pouch, one-piece system, two-piece system. So the wafer we're going to talk about in the next slide, and then the pouch after that. But the one-piece system is essentially when the wafer and the pouch are stuck together. The two-piece system is when you have to either click or stick the wafer and the pouch together. And again, I'll go through this a little bit more. Then you have flexible systems, rigid systems, flat, convex, pre-cut, cut to fit, lock and roll, high output, clip. Then there's all kinds of accessories. So let's dive into it a little bit more so that you can better understand it. Let's first start with the wafer. This can also be called a barrier or a flange. This is the sticker part of the ostomy pouching system. The goal of the wafer is to cover the intact skin to protect it from whatever's coming out of the stoma and to keep the pouch attached. It can come in a flat, meaning that the entire sticker part is flat, or convex, where it kind of dips down into the skin a little bit. The benefit of a convex wafer would be that it pushes the stoma up through the hole a little bit more so that the drainage from the stoma or the effluent would go into the pouch. These wafers can come in cut to fit, meaning you identify the size of your stoma and you cut it to fit the size of your stoma. It can come in moldable, where instead of cutting it, you're simply molding it open. And often that means rolling it back onto itself. You could stretch to fit, which I describe as like a pie crust. So you stretch it out to the size of your stoma and then you stick it to the skin around it. Or there's pre-cut. So pre-cut is after that 6 to 8 week period, you know the size of your stoma. They often pre-cut them only circularly. So that might be an issue if you have a loop. But once you identify your size, you can just order the hole to be the size of your stoma. As I mentioned, in a one-piece system, the wafer and the pouch are going to be stuck together. And in a two-piece system, you have to put them together. Then we have the pouch. So on the bottom, this is an example of a closed pouch. So in a closed pouch, you can see there's no way to empty it. So every time that pouch is full, you have to take the pouch off, throw it away, and put a new pouch on. If you have a two-piece system, you don't need to take the wafer off every time. So you don't have to worry about ripping your skin off or having adhesive issues because you're just changing the pouch. One of the things I like to highlight as well is that these are sticker options. So some pouches stick to the wafer with this sticker option versus others click together, almost like a Tupperware lid, so that you can feel them click together. And even some companies have a click system where you put the rings together and then you click something shut in order to lock it in place. The pouch on the top left, I is showing you a drainable pouch, and this is a stool pouch. So this means it's either an ileostomy or colostomy. This is one that you would essentially open it up, drain it out, clean it, and roll it back up. I'm probably showing my age, but the bottom of the pouch is almost like a change purse that when you push on each side of it, the mouth opens up. And so that can help with emptying. And then I don't know if you can notice the difference between the tan in the drainable pouch. Once you roll up, what they call is the tail, which is that bottom portion that you open and close in order to drain it, you can actually tuck it into the pouch itself so that you don't have that that tail that is rubbing in on you. Often the darker tan material is more of a cloth-like and the lighter tan is more of a plastic. The goal is that you will empty the pouch when it is a third full. If you wait too long, there's a higher risk that you'll have leakage or that the pouch will fall off or that you will decrease your wear time. For urostomies, all of the pouches have a spout bottom. So there's typically a mechanism that you would switch or you would push on a switch in order to open the valve for that spout bottom. There's one that has a drop on it, and I always say when the drop is showing, then liquid is flowing. But all of the different companies have a slightly different mechanism for it. Ostomy products. So I have a lot on here, and I know in the Frank and Lizzie show, we go into each one individually. I'm just briefly going to talk on all of these and then go into a little bit more detail on just a few of them. So ostomy products that you see here are a Stoma Genie. That is a Stoma output capture cartridge. That's to just help capture your Stoma output while you're changing your pouching system. On the upper middle, we have an Ostoform that has a spout on it. So it's like a silicone spout that has, which they call flow assist, that will help the output go into the pouch rather than underneath the appliance. And it's surrounded by a hydrocolloid barrier ring. Below that in the middle, you have a standard ostomy belt. This can help keep the pouch tight to your skin and prevent it from pulling off of the skin, or it could help with pulling the pouch closer to help your stoma stick out slightly. On the upper right, there's two different companies' versions of Stoma powder. This can help dry up skin irritations that are underneath the adhesive before you put on a new pouching system. Typically, after you clean the skin, you'll put on the powder, you'll wipe away the excess, and then you'll put a skin prep over top of it so that you're kind of sealing that area off, and then it's clean, dry for you to be able to put the new pouching system on. Directly below the Adapt Stoma powder is the Adapt Slim Barrier Ring. Barrier ring is a hydrocolloid. I think of it almost like a wax ring underneath your toilet. It's going to fill in gaps and crevices in order to help create a better seal. It can also provide just a little bit of pressure to help get that stoma pushed out. We also use these in wound care for a variety of reasons as well. On the complete bottom right-hand side, we have Adapt Paste, which is most manufacturers make paste, and this one just happens to be from Hollister. Adapt Paste is a lot like a caulk. You're going to use it to fill in the little cracks and crevices, but it's not going to fill in a big one. That's when you would use the barrier rings. To the left of that is adhesive extenders. And so this is to help put around the wafer portion in order to just give you a little bit more security at the edge of your wafer. Those three oblong, almost cat eye things are convex barrier rings. And I'm going to talk about them a little bit more in the next one. The black clothing in the middle is actually a form of an ostomy belt. So it's a cover and a belt, and it can help provide a little bit protection as well. Mastisol liquid adhesive is a very strong adhesive that helps the pouch stick. I typically don't recommend Mastisol because it can cause irritation of your skin from the adhesive pulling your skin off. And then 10 Aces is actually a silicone adhesive spray. It's newer to the market. We've had really good experiences with it so far, but essentially you spray it onto the back of the wafer, you kind of spread it around, and then you wait just a minute, and then you can apply it to your dry skin around your ostomy, and it helps with improved wear time, decreased irritation, and just having a little bit more confidence in that pouch staying in place. So for barrier rings, who gets it and what type? So there's basically moldable rings. So they're a lot like Play-Doh. You can tear them apart. You can make them different shapes. They come in different thicknesses, widths, things like that. The convex kind, the ones that look like cat eyes, those are not typically moldable. They're definitely harder. So if you have a flat appliance and you want to make it convex, you can get these convex barrier rings. And there's all different kinds. You can get deeper ones, you can get soft ones, there's silicone ones. Why would we use this? Well, if we have a patient that is experiencing leaking issues, if they maybe have a flush stoma, meaning that the stoma is more at skin level, or if it's a retracted stoma, meaning that the stoma is below the skin level, it helps prevent leakage issues. And then also if somebody has high output, this can help improve their wear time. You would put this directly around the stoma, or you can put it on the wafer itself like you see in the lower middle area. Belts. So belts can be amazing. They can be wonderful for helping increase confidence. Some of the belts that you see here are actually for hernia support as well. So these are helping prevent that protrusion of the bowel through the stoma or having the stoma prolapse. There's also belts that help protect the stoma from any trauma. So particularly in those patients that are very active, we might need to protect the stoma if they're doing contact sports, or if they have a job where potentially they're coming in contact, or if they have to wear a belt. So like I had a patient that was a construction worker who wore this belt that guarded his stoma in order to help protect his stoma from his belt that he had to wear with all of his tools on it during the day. Gas and noises. So this is one of the things that I talk to my patients a lot about. So gas is a very common thing in ostomies. And so you can see the bag kind of fill up like a balloon. And so you can either burp the bag, which means that you would separate the wafer from the pouch and allow the air out. That would be one time you might notice a smell because essentially you're farting in the bag and then opening the bag. Most pouches have a odor lining in them so that if everything is closed, you shouldn't notice an odor ever. You may also add this little vent system on any pouch. That's called an easy vent. Or you could also buy a pouch that has a built-in filter. So if you look on the bottom middle on that picture of that tan pouch, the very top is that little white, maybe half moon or maybe kidney bean looking thing. That is actually a filter, a charcoal filter. So it allows diffusion of air through that filter through a charcoal so that it will slowly release. If you have a lot of gas, that may not be the best option, but if you have a little bit of gas, that's a good option. The other one that I want to talk about is in the middle on the left, that picture of the gentleman with the black dot on his bag. So that's called an osteopath, and that is a device that essentially puts pressure on the stoma in order to help prevent fart noises coming from the stoma. It's based upon the reed theory that when something is unopposed in vibration, that it will be louder, whereas this will help muffle that noises as well. And then we always want to talk to patients too, because medications, food choices can also affect the gas and noises as well. So just some basics on how to empty a pouch. And the four main things are going to be that you prepare, you drain, you clean, and you reseal. So when emptying that, you want to sit or stand over a toilet. Ideally, you'll place some toilet paper in the bowl to prevent any splashing. If it's a drainable pouch, let's say for a stool ostomy, you would either unclamp or unroll the pouch tail, let the contents drain in, wipe the opening with a clean toilet tissue, and make sure the outside is also clean as well. One accessory I forgot to mention is that there are lubricants and deodorants, and sometimes it's a lubricant and deodorant in one. You would add that to the bag after you empty it in order to help with any malodor, or if you would add a lubricant if the stool is thicker and it's having a hard time coming out. After you've cleaned the bottom thoroughly, you close it shut by either resealing the tail back up or reclamping it. If you have a urostomy, you would just open and drain it into the toilet, and always washing your hands before and after, pulling your clothing up to get it out of the way. Ideally, you can sit on the toilet and empty it in between your legs. Some people find I call it the cowboy method, where they actually face the back of the toilet to be a little bit easier because then they have a place to kind of set a few things down. I always recommend getting an elongated toilet for this, but there's lots of ways to do it. And then this is how to change a pouch. And this is a very basic thing. So it's going to be similar in that you'll gather your supplies, you'll empty it before you change it. You'll remove the old bag. Now, some people use an adhesive remover. Some people don't. But the recommendation is to gently peel it away from your skin, providing backward pressure on your intact skin, and pull the bag down away from the stoma so that if anything comes out of the stoma, you're still able to capture it. You're going to use warm water and a soft cloth to clean the skin around it. If you want, this is when you could use that stoma cartridge or that stoma output cartridge in order to collect any output that may occur while you're cleaning your skin and preparing your supplies. You'll have to dry your skin well, but you don't want to be aggressive in terms of rubbing, because that can cause irritation. That will not be good for the appliance sticking. If you need to, measure again. If not, just inspect your skin, make sure there's no abnormalities. Use your accessory products if you need to, and then prepare your wafer. So I typically recommend cutting your wafer ahead of time if you have to do that, but you want the wafer to cover your skin, but not your stoma. So you're gonna cut the wafer to just a little, like I'm talking millimeters bigger than your stoma. And some people put the wafer on first and then their pouch. Other people connect the pouch before the wafer. Obviously, this is for a two-piece system. It's really totally up to you which one. And then typically you take your hands and you put them directly over the wafer after you're done, holding pressure for about 30 to 60 seconds. The warmth of your hands will actually help the adhesive stick to your skin and improve the wear time of the pouch. Skincare. So, skin around the stoma can become irritated, often due to moisture, adhesive sensitivity, skin stripping from the adhesive. And that leads to pain, decreased wear time, and the inability of the pouch to adhere. What you want to do is make sure that your skin is as dry as possible. So the first thing that you can do is to fix the root cause. If leaking is the reason that you're having an irritation, then we got to identify what's causing the leak. Is it you need an accessory product? Is it that your skin's so irritated the pouch won't stick? Is it that you're in the wrong type of pouch? That are you not emptying it soon enough? Those type of things. The other thing is that it's possible to develop an adhesive sensitivity to certain brands. So my recommendation is to try a variety of them. I know I'm sensitive to acrylic adhesives, but hydrocolloid adhesives I do okay with. So, and it depends on the brand and what their additives are. Another reason to work with a wound ostomy continence nurse or a certified ostomy specialist. Just quickly, some resources. There are care programs by all the manufacturers where you can connect with somebody who is trained in the variety of supplies that they have, and you can talk about whatever challenges you're facing. They also have lifestyle things such as sexual health, diet, how to be active in the community. I highly, highly, highly recommend if you work with ostomates or you are an ostomate, please join the UOAA at www.ostomy.org. They have a wealth of information. They have a wealth of resources. They can get you connected. They are amazing. Please reach out to them. And then also the WOCN also has patient education resources on their website as well. And just know that you are entitled to ask for a certified ostomy specialist. So I want to thank you guys so much for watching this today, and please share our information to get the word out. We would love to partner with you in the future, and be sure to go to our website, which is www.frankandlizzieshow.com, and you can download an ostomy checklist for free. Thanks so much.